critical care. Most of all of us, we know very well AF management in general population, but now in this lecture, we'll try to look more from the scope of the critical ill patient and the critical care. Of course, arrhythmias is very common in the critical care patients, and this arrhythmia with a brady or tachy, we often to see it in any patient who is admitted in critical area.
لو سمحت يا مايكل تحط شير سكرين
started
نقدر نتابع معاك أكتر.
حضرتك شايفين as we were saying in arrhythmias is very common in critical patient with a brady or tachy, and from these arrhythmias atrial fibrillation contribute to the majority. هو most common type of arrhythmia to face in the critical ill patient. Management في معظم الأمور it is like the general management of AF in the general population. However طبعا الكرايتيريا بتاعت الكريتيكال ill patient usually الهيموديناميك ستيتس بتاعتهم associated comorbidities. These patients require special tailoring في المانجمنت for atrial fibrillation. Special clinical consideration should be taken. This is what we are going to try to put the focus over the next few slides in this picture. So our agenda for today is what is the epidemiology of atrial fibrillation in the critical ill patient? What is the pathophysiology? What is the pathogenesis and how patient critical care are more vulnerable to develop atrial fibrillation? How you can approach proper diagnosis and what is the diagnostic workup that you should follow up in this critical ill patient? Then we are going to talk about how we are going to manage the unstable patients, and then how you are going to manage the stable patients, and finally, what will be your long-term treatment upon discharge of this patient from the critical area. So first of all is the epidemiology. AF is the most common arrhythmia in patient hospitalized in the ICU. And actually, this has been reflected in the most recent guidelines, the American Heart Association scientific statement in 2023, where the definition of AF, a new definition has been introduced, which is acute atrial fibrillation. And in this definition, AF detected in the acute care setting or during acute illness has been given a certain terminology, the acute AF. This is in replacement for the older terminology, which is the secondary AF. And the reason for this is that the scientific committee and scientific group feel that terminology of secondary AF carry in its meaning that this AF is secondary to a certain correctable factor, and once you correct this correctable factor, AF is no more risk for this patient, which is not the case. Their hypothesis is that these patients that develop AF in the critical ill are mostly have substrate for developing AF, and this patient would otherwise develop AF in certain stage of their life, and it is just that the acute state or the triggering factors they have been exposed make this AF manifest or revealed. And also many of these patients also may be having AF before admission to the hospital, and it was just diagnosed once they admitted in the critical care. So a special terminology is now given in the most recent guidelines, which is acute AF. And this acute AF could be either paroxysmal or persistent, and could be symptomatic or asymptomatic. You can just detect it in the rhythm monitoring or ECG while the patient is in critical care admission. Also, from the risk factors that make AF common arrhythmias in the critical patient is sepsis. The presence of sepsis and oxidative stress make atrial fibrillation more common in acute critical ill patient, and this incidence increase with severity of sepsis. As we see, it reached from 8 to 10 in the general, just mild degree of sepsis, and could reach to 23 to 44% of septic shock patients develop atrial fibrillation. Also, in the critical ill patient, especially post-operative patient, they are at increased risk of developing atrial fibrillation, and the risk with cardiac surgery is more than non-cardiac surgery. Cardiac surgery risk depends on the type of the procedure. In CABG patient, it reaches almost 1/3 of the patient who do CABG are at risk of developing post-operative AF, and this percentage reach to half, 50% and 65% if it is associated with valvular replacement surgery, according to the most recent guidelines. Well, what about the pathophysiology? This model, which is also applied in the general AF incidence population, it's also applied for the critical AIDS. Usually there is a substrate, patient have a substrate. This substrate could be either due to chronic factors like volume overload, like cardiomyopathy, like hypertension, like any associated valvular disease, like any pulmonary disease, all condition lead to creation of anatomical remodeling of the atrial myocardium, and a scar started to form within the tissue. And once these patients are exposed to triggering factor in the critical care setting, in the acute illness, like volume changes, volume depletion, loss, or any electrolyte imbalance, or the exposure to vasopressor or eutropes, or hypoxic stress or oxidative stress, or any toxin for septicemia, all these triggering factors in the presence of these substrates will lead for this patient high susceptibility to develop into atrial fibrillation. And when AF occur in the critical ill condition, there is consequent, of course, there is risk for developing hypotension, myocardial ischemia, patient may develop pulmonary edema or cardiogenic shock, and end organ dysfunction like encephalopathy or renal shutdown or liver impairment. AF also is associated with secondary complication like cardioembolic, thromboembolic complication, and this is of course a big concern, of course, heart failure and longer hospital stays, reduced quality of life, and increased mortality from 2 to 5-fold increased risk. What is your diagnosis for patient AF? How you do workup for this patient? First of all, of course, and the most simple is the 12-lead ECG. As we know, all 12-lead ECG diagnosis for AF include criteria that there's absence of the T wave. You can see fibrillatory wave, coarse or fine, and associated with this is the irregularities of the QRS complexes. This is the basic ECG. Important to note when you look at the ECG for diagnosis of AF, it is not just to diagnose atrial fibrillation. You have to look, do proper scanning for the ECG, see if there is any associated pathologies. Like in some cases, you can find associated ischemia, as in this example, you can find ST elevation in association with the AF. So this is very important not to miss any associated pathology that may be actually the reason that triggers the patient to develop atrial fibrillation. Another workup of the patient after the ECG is, of course, these patients need echocardiographic evaluation and X-ray, and of course, serology, including electrolytes and thyroid function to identify any correctable factor. And in special populations, those who have surgery, cardiac surgery patients who develop post-operative AF, in this patient, you should have early suspicion that this patient may have pericardial effusion, and it is a triggering factor, so you have to rule out this by either transthoracic or transesophageal echocardiography. How you are going to manage a hemodynamically unstable AF patient in the critical area? The most important, of course, is to restore adequate perfusion pressure of the patient by IV fluid, by vasopressors, and you also should take care for this patient. You should proper adequate analgesia because the patient is in distress and pain. This will lead to more and more harmful sympathetic activation. And also you have to maintain sufficient oxygen supply from the myocardium by oxygen therapy. And the main and the golden rule and the golden therapy, of course, in this hemodynamically unstable patient is emergency electrical cardioversion. Any patient who have a huge chest pain, dyspnea, hemodynamic instability, then in this patient, you should go for electrical cardioversion. And before doing electrical cardioversion, if you can give for the patient, of course, adequate sedation and analgesia. And if there is a risk of aspiration, then you will proceed with airway secure by intratracheal intubation. The success rate for giving electrical shock for this AF patient depends on many factors, including how long has been this AF, what is the left atrial size, is it dilated or not dilated, the chest wall impedance, and some tips that could help to achieve successful outcome from this electrical cardioversion include the placement of the electrodes itself that you are going to give the electrical shock. The anteroposterior position is preferred for the anterolateral position. This is optimizing the vector for the current delivery using biphasic waveform. And of course, if the patient have a chance to be pre-treated with antiarrhythmic drug or he already on antiarrhythmic drug, this increases success rate. And in special situation, in patients who have high body mass index, like obesity patient, you can use the paddles manual and you apply augmented pressure. This will help more the success rate for the delivered electrical cardioversion. An important notice is that when you deliver electrical cardioversion for a patient and it's failed and you are going to give another repeated shock, to remember that the synchronization mode is by default by all DC shocks machines return to the non-synchronous mode after each shock therapy. This is to avoid, to allow for immediate defibrillation. So if you are going to give repeated electrical diversion, each time you have to remember to activate the synchronized mode to avoid giving electrical shock on the vulnerable repolarization phase of the cardiac cycle. After you give electrical cardioversion for this patient, you have two considerations. First of all, the thromboembolic prophylaxis anticoagulation. It should be continued for at least 4 weeks to prevent any cardioembolic complication from the atrial stunning. And the second thing is the antiarrhythmic treatment that you are going to give the patient to try to maintain his sinus rhythm after achieving successful electrical cardioversion. So this was the management important issue in the management of hemodynamically unstable AF in the critical ill patient. How we are going to manage the stable patient with AF? The first thing that you are going to think, are you going to do rate control or rhythm control in this patient? Generally, rate control aims to, you will leave the patient in atrial fibrillation. However, your target is to control the ventricular response by giving some medications that control the AV nodal conduction, like beta blocker, calcium channel, digoxin, or amiodarone. And on the other hand, the rhythm control mainly target for this patient who cannot tolerate this synchrony is to restore the normal sinus rhythm, either electrically or using pharmacological agent that can restore sinus rhythm. The general rule is in whatever strategy you are going to take, whether the rate control or rhythm control, you have to focus on correcting any underlying triggering factor, any possible things that could have been contributed to AF development, like electrolyte imbalance, like hypoxia, like volume changes, all these things that could be corrected, you should focus on it in order to accelerate that the patient restores sinus rhythm easily. Also, from the general rules, as we said, electrolyte derangement should be corrected and you should be usually kept to the upper normal level. IV medication is the preferred one in the critical area situation, of course, because they have faster onset and more reliable action, and usually start with the agents that have low risk profile and short half-life, like beta blocker. And when the patient is refractory to this beta blocker, then you are going to resort to the more potent or more complex and more possible side effects like the amiodarone medication. For the rate control approach, what are the available options? The first one, as we said, the beta blocker. It is the initial drug of choice in most of the cases. Of course, if the patient is severely myopathic or in decompensated heart failure state, or in the patient severely hypotensive, then you will not be able to use beta blocker. However, in most of the scenarios, you can give at least short acting beta blocker like IV metoprolol or esmolol. Metoprolol dose usually is from 2.5 to 5 milligram boluses to be repeated every 5 to 10 minutes up to 3 doses. So this would be your initial choice. Digoxin can be given in patient. However, the point in digoxin will take some time to control the AF rate. Usually it is given doses 0.25 to 0.5 milligram bolus loading dose to be followed every 4-8 hours by 0.25 milligram up to 1 to 1.5 gram. This is the total dose, and the maintenance dose will be 0.25 milligram once daily. Digoxin has to be reduced the dose in patients who have renal impairment. You have to do renal correction, which will be 0.125 milligram daily in the patient who has creatinine clearance from 60 to 90, and it will be every other day if the creatinine clearance is less than 60. For the non-dihydrogen calcium channel blocker, they also can be used. The IV forms, verapamil or deltism. However, of course, the non-dihydrogen calcium channel blocker are more strongly negative inotropic, and they may have profound hypotension or reduction in the cardiac output in patients who are borderline. What is the target heart rate? So you are going to give this medication to achieve controlled rate of the ventricle. But what is your target? How far do you want to reach the heart rate? This, of course, depends according to the hemodynamic status of the patient. You need to optimize the cardiac output of the patient and maintain adequate tissue perfusion guided by different measures for measurement of cardiac output, like pulse pressure and mean arterial pressure. However, for just rough numbers that will help, the guidelines recommend aiming a heart rate less than 110 beats per minute. This is as a general for the critical ill patient who have AF, that you are going to adopt rate control strategy. And in some patients who are highly symptomatic or those patients who have associated LV dysfunction or have implanted cardiac resynchronization therapy, you may need to achieve more strict lower heart rate down to 80 beats per minute. This was based on trials by the AFFIRM and the RESTO trial. Also, special population is a post-operative, post-cardiac surgery patient. In this patient, the studies showed that your aim rate control to be less than 100 beats per minute. So what about the rhythm control strategy? Rhythm control strategy, you should seek it in those patients who are intolerant for this AV dyssynchrony. And you can achieve this either by pharmacological or electrical management approach. Of course, the electrical cardioversion is a rapid and very more effective than the pharmacological one, and it's a safe one. However, the drawback or the trade-off is that you will need to give sedation in this patient who we are going to plan for electrical cardioversion. The pharmacological agents that can be used for rhythm control include different options. First is the ebutalide. Ebutalide is a fast-acting medication. It has success rate high for cardioversion of the patient. However, it has main concern that it can lead to long QT with consequent torsade de pointes. So in these patients, they should be carefully monitored and observed with administration of the ebutalide. And another drawback of the ebutalide is that it's short-acting. So if your patient have triggering factor or have risk factors that is still not corrected and you are expecting that he will have recurrence of the AFib, ebutalide will not be your good choice. The second one is, of course, class 1C antiarrhythmic drug, flecainide or propafenone. But of course, this medication cannot be given in patients who have structural heart disease. And the advantage of this medication is that they can be given by the oral route and you can continue the maintenance oral doses after you give this medication. The third one, which is the most common, is the IV amiodarone. Amiodarone, of course, has the advantage of that you can, with long-term, shift and maintain on oral doses for long-term. Its main drawbacks is that it takes some time to give its effect. It has longer time. And amiodarone, of course, is one of the pro-arrhythmic medications that lead to long QT. And so many drug interaction has to be taken care while you are administering in the critical care scenarios. The dose of the amiodarone is single dose of 150 to 300 milligram bolus to be achieved over 1 hour. This to be followed by 0.1 gram per kg for maintaining loading dose over the first 7 to 10 days. And then in atrial fibrillation scenario, you will continue on a maintenance dose of 200 milligram oral daily. Another medication that can be used for rhythm control is the vernacular. It's a new antiarrhythmic agent. It targets certain atrial-specific channels. The dose of the medication is 3 milligram per kg over 10 minutes, and then you wait for 15 minutes. Usually, in success rate is from 50 to 70% to cardiovert the patient within 10 minutes. If the patient didn't cardiovert after this 15 minutes, then you will give a second bolus dose of 2 milligram per kilogram over another 10 minutes. You have to take certain precaution. Vernacular cannot be given in ischemic heart disease patient or severe aortic stenosis or hypotension or patient in decompensated heart failure, or if the patient has been received another antiarrhythmic class 1 or 3 within the 4 hours preceding its administration. However, it's one of the medications that's very have a high success rate, and actually we are using it frequently in our daily management scenarios to restore sinus rhythm with a high success rate and low side effect profile. Post-cardioversion, you have to monitor the patient, monitor for those patients who received pharmacological, whatever the pharmacological agent, you have to keep monitoring the patient for a duration at least equal to the half of the therapeutic half-life of these medications that have been used. And for this patient who have received electrical cardioversion with sedation or anesthesia, you will follow the same protocol of management of post-anesthesia for any patient. For ebutalide, as we mentioned, because of the risk of long QT and torsade de pointes, this patient has to be monitored carefully over the first 4 hours post-administration with the patient attached to patches for defibrillator-ready standby. And another issue that's common seen in the patient, after you restore sinus rhythm, you may find that the patient is in sinus bradycardia. This is common scenario because the S node usually is suppressed by the automaticity is suppressed by the preceding atrial fibrillation. Most of these patients will not require any intervention from the side, just monitor the patient and supportive measures with no further management usually required. Now, what will be your plan when you are going to discharge this patient, or even after you cardiovert this patient? What is the long-term management of this patient? Of course, the most important thing is what is your anticoagulation strategy for prevention of thromboembolism. And for this, in the acute care scenario, we follow the general recommendation for thromboembolism prophylaxis in the general population. It will depend on the Schatz-VASc score. And Schatz-VASc score usually more than 1 for males, more than 2 for females. For this patient, you will consider therapeutic anticoagulation lifelong. And you have to also, of course, balance what is the risk of bleeding of the patient using the Hasblet score. And for those patients who have Hasblet score more than 5, they are at high risk of bleeding. So there is no contraindication. You cannot say, I'll not give anticoagulation for this patient, but this patient needs frequent monitoring and frequent observation. You may need to suspend for some duration. So it's a matter of risk-benefit, but as a general rule, you have to, of course, give proper thromboembolic prophylaxis to the patient. In patients who have post-operative AF, the anticoagulation management also follow the same guidelines of the general population. And it's important to emphasize that you usually have to balance the risk between thromboembolism versus the risk of bleeding, and usually shared decision-making should be done with the patient. You have to involve your patient in the decision. You illustrate for him the benefits and the risks of giving the anticoagulation. And for those patients who have really absolute contraindication for anticoagulation, we can consider appendage occlusion, whether this is done surgically or interventional using appendage occlusion device. This can be resorted for some patients who have absolute contraindication for anticoagulation. Regarding the long-term rhythm management, also you should involve your patient about what type of medication you're going to give him, what is the side effects, what is the preference. So a third decision should always be considered also. And in the East Afnet 4 trial, the most recent trial, it was found that those patients who has maintained on rhythm control medication and managed to reach 1 year free of AF post-cardioversion, they have really lower risk of adverse cardiovascular outcomes. This was in the general AF population. Whether this also apply for the critical ill patient, it's still a matter of further research. And it's important to keep in your mind that these patients, many of them will have recurrent AF after they are discharged from the critical care area, and they may be asymptomatic. So you need to do long-term monitoring for this patient using the Holter or patches monitoring or event loop recorder monitoring, and applying digital watch monitoring for this patient to monitor for those patients who have recurrence. And in some patients, it may be difficult to maintain rhythm control for them, and they are refractory to the medication. And for these patients who are highly symptomatic, you may consider for them catheter ablation, pulmonary vein isolation. This is done through an EPCAS lab. Or in those patients who are refractory to all these things measures and they are highly symptomatic, you can consider epinodal ablation with permanent biventricular pacing to reduce the symptom and increase the function capacity of the patient. And of course, in these patients, a multidisciplinary approach should be considered with also patient involvement in the decision. We will talk about special condition for AF in the critical air scenario, which is commonly seen. The first one is the stroke. It's common in the critical area that you find the patient who have a stroke and you find with him atrial fibrillation. So some important, it will follow the same general guidelines. However, some points that worth mentioning is that in this patient, usually the embolization is in the anterior circulation, in the middle cerebral artery. This is most common, more than the vertebral-basilar circulation. And what is the significance of this? Significance of this, and these patients are good candidates for mechanical thrombectomy. Another thing to note in this patient with AF and stroke is that the risk of re-embolization is opposite to what usually we might think. It's low. The risk of re-embolization is low. The risk of hemorrhagic transformation is high in this patient. And that's why in this patient, per guidelines, you do not give early anticoagulation once the patient develops stroke and AF. Usually, it will be after 4 to 14 days according to the thrombotic or hemorrhagic risk balance. And there are currently ongoing trials evaluating what is the optimum timing to start anticoagulation and the doses, like the ELAN optimum timing start trials. According to the results, we will have more solid data. And of course, in this patient, a multidisciplinary approach is necessary. Another special population for AF in the critical area is the hyperthyroid patient. Of course, hyperthyroidism will lead to triggering atrial fibrillation. And in this patient, your goal for management is, number one, is to restore the urothyroid state of the patient by managing the hyperthyroidism. And beta blocker is the preferred medication to be given for rate control in this patient. One thing also is that hyperthyroidism is associated with a hypercoagulable state. There is increase in the coagulation factors. However, still in the guidelines, you should not include something special in this patient, and you will follow the general SHADS risk stratification in the management of this patient population. What about postoperative non-cardiac surgery patient? These patients common to develop AF because of adrenergic surge and volume loss and shift in their autonomic tone and fluid status. For this patient, usually after correcting the triggering factor or the predisposing factor, they may spontaneously revert to sinus rhythm. So a rate control strategy will be a reasonable approach in this patient. And of course, concomitant with the rate control strategy is aggressive management of any underlying triggering. And most of these patients, they will resume sinus rhythm spontaneously. Anticoagulation is indicated in this patient. And of course, you have to balance the surgical hemostasis status by shared decision with the surgeons. What is the risk of bleeding in this patient? And accordingly, you have to give the anticoagulation after shared decision with from the surgical point of view. What about cardiac surgery patient? Also, as we mentioned in the beginning, there is high incidence of AF in the cardiac surgery. What is the special consideration in this patient population? It was found by the studies and has been proved that prophylactic treatment for this patient by either beta blocker or amiodarone, this will help to prevent the incidence of post-operative guidelines. And according to the most recent guidelines, this is a guideline recommendation. Of course, beta blocker is preferred because of its low side effect profile, and you can give amiodarone in those patients who are at higher risk for developing post-operative AF, like as we mentioned, in patients who have concomitant valve surgery with CABG. Other agents that has been proposed, however, there is limited evidence for their use, including like colchicine, ACE inhibitor, statins, and non-steroidal anti-inflammatory drug or omega-3 fatty acid. And some surgical techniques also has been proposed that they are associated with lower incidence of post-operative post-cardiac surgery AFib, like posterior left cardiotomy or botulinum toxin injection. However, they are still under research, and there are currently 2 ongoing studies, the PALAX and the NOVA trial, that evaluating this post-operative prophylactic approach. To consider also in this patient, as we said in the general cardiac surgery, is anticoagulation is indicated in this patient, of course, and actually these patients usually are at high risk for developing thromboembolism. So you have to always share discussion with the cardiac surgeon about what about the status of the surgical hemostasis of the patient and optimum timing for starting anticoagulation. This should be individualized from patient to patient according to the patient current condition. And there is currently also the PACES study evaluating the proper anticoagulation for post-cardiac surgery operation. So to conclude, dear colleagues and dear professor, atrial fibrillation is the most common arrhythmia in patients hospitalized in the ICU, and it's associated with increased morbidity and mortality. Management approach should be tailored according to patient hemodynamic stability and associated comorbidities. Acute AF is associated with a high risk of long-term AFib recurrence. This warrants clinical attention during the acute stage, acute hospitalization, as well as at your transition of care and for the long-term follow-up of the patient. And multidisciplinary approach should be usually included for the long-term anticoagulation and the long-term risk management of these patients upon discharge of the patient from your critical area. Thank you.
شكرا جزيلا يا دكتور مايكل. وطبعا قال يعني هقول كومنتات فيها اعتراضات على بعض الحاجات اللي قالها. وهو قال ان احنا دايما كنا بنحب دكتور حسن يقول لنا نمشي على الجايد لاين. طبعا الجايد لاين بتبقى بناء على ناس عندهم خبره، بس اللي انا عايز اضيفه ان انت من ممارستك وخبرتك بتبتدي تلاقي حاجات مختلفه عن الجايد لاين بتقولها، فبتضيف انت لها. وانت او غيرك لما بتكون بقى حاطط دماغك في العلم بتروح مكبرها على عدد كبير من العيانين وناشرها. زي انا البيل ان ذا بوكيت دي اللي بعملها من 30 سنه، لحد ما واحد عملها وكتبها في مقاله ان اللي بيجي له بروكسيزمال رير اف مرتين في السنه يبقى في جيبه الريتم نورم او الفريكانايد وياخده ولا انتي كواجولانت ولا حاجه. الاعتراضات بقى او الكومنتات مثلا قبل من الاخر الاول قال ان الستروك يفضل الانتي امبوليك ستروك طبعا، يفضل ان هو يتاخد الانتي كواجولانت ليتر من اسبوع لاسبوعين. الحقيقه الكلام ده اتغير في اخر سنه، وانا من الناس اللي من غير ما يتغير انا بعمل كده. اي واحد عنده اف وجاله ستروك مصيره يجيله تاني. وعندي قصة شهيرة، علاء شفيق احد اهم اساتذة النساء في القصر العيني جاله امبوليك هيمبليجيا بي اف. جه الدكتور اسامه علوان قال اوعوا تديله انتي كواجولانت. قلت له لا، ما هو الراجل جاي فايق وهيمبليجيك بس. قال لا. طبعا على تالت يوم جه نظر امبولاس ومات فيها. انا من ساعتها الكلام ده في الثمانينات التسعينات اي واحد بيشوفه اكيد ستروك بحط له ميني هيبرين لحد ما يعدي 3 4 ايام واحط بعد كده فول دوز. الكلام ده بقى واحد عمله وحط ونشره بحث من اعتقد 6 اشهر، جبت لكم السلايد بتاعته، انه في الستروك المايلد ومودريت يو كان ستارت الانتي كواجولانت وزين 3 دايز. دي اول تعليق. وانا شايف انه بالخبره. في تاني تعليق بقى، الفراباميل كريت كنترول. انا يعني ليا قصه مشهوره، امر الاقي واحد رابط اف اقول لهم يا جماعه بتدوا ايزوبتين؟ لا لا لا، ده لونج تروبيك يا جماعه، ما هو سلونج ريت بالفراباميل هينلفاي المايلد نيجاتيف التروبيك افكت. مش عارف، مايكل حضر احمد عبد العال من اوائل الناس اللي اشتغلوا معايا اريزميا والكتروفيسيولوجي، وهو اول واحد بعتناه على كارتو فرنسا في نانسي. فقال لقيته بيقول لي زرته هناك، يا دكتور حسن احنا كنا دايما نعترض على الفراباميل في واحد عنده رابيد اف وهارت فيلير. لقيت اليوت اللي هو رئيس القسم بيعمل زيك كده. قلت له طبعا، لان هي واحد الهارت ريت عنده هارت فيلير واي اف 120، لما اخليها 70 و80 بيتر فيلينج بيتر اوتبوت. فده يعني حاجات تيجي بالخبره من غير مبالغه طبعا. والاورال عمره ما بيعمل هايبوتنشن. الحاجه الثالثه بقى اللي هي الاكوردنج تشاد، دي برضو جت من تجربه شخصيه وبعدين قلتها في مؤتمر من كام سنه كانت عاملاه ميرفت المعاطي. لقيت راجل امريكاني بيقول لي انا وافقك على الكلام ده. ايه بقى؟ ان احنا اكوردنج تشاد الراجل عنده 40 سنه والاف باروكسيزمال، ولا عنده ضغط ولا سكر ولا عنده بريفيوس ستروك ولا هو واحده ست، يبقى تشاد زيرو، مش حتى واحد. يبقى ما نديش. عملت كده بالجايد لاين ما اديتوش. جالي بعد كده بسيفير هيدك. قلت له لا لا، الدماغ مليانه بقى عينين ودان واسنان. راح لدكتور تاني عمل له سي تي لا اوكسيبيتال انفارش. ابتديت اسال عيان بقى، هو رجع لي الحمد لله ثقه. لقيت ان الاتاكس اللي بنقول عليها بروكسيزمال دي عنده prolonged اتاك. فده التعديل اللي انا ايه، لما واحد بيجي له prolonged اتاك اوف بالساعات وبالنص يوم، اتس بيتر فور سيفتي انك تحط الانتي كواجل. لان كارثه انك تشوف واحد جاله امبوليزم هيمبليجيا بسبب الاف وانت كنت تقدر تمنعها. دلوقتي حتى الحكايه بقت سهله في وجود النيو انتي كواجلانت عن زمان. اخر حاجه بقى دي السؤال لمايكل هو اللي هيجاوب. واحد دخل لك واحده ست، ودي برضه عشان لها قصه، و unstable اف، وانت بتقول نعمل على طول كارد فيرجن. فلما سالت اهل العيان محدش قدر يوضح لك هو امتى حصل الايه الاي اف ده. فنو واي ان انت تعمل كارد فيرجن، عشان زي ما حصل مع احد زملائنا هيمبليجيا اون ذا تيب. فتعمل ايه بقى؟ واحده داخله بانستيبل هيمودايناميك اي اف وجات لك ايه يعني سيفير هايبوتنسيف ورابيد اف ومش عارفين حصلت امتى. اتفضل.
تمام دكتور حسن، ميرسي جدا للكومنتس بتاعت حضرتك. في بس هيك النقطة بتاعت الانتي كواجليشن مع الستروك. هو زي ما كنت وضحت لحضرتك، يعني هو الريسك بنفيت في التايمينج اوف اونست بعد immediately after the acute stroke، ان بيبقى الريسك اوف hemorrhagic transformation higher عن الريسك اوف ري امبوليزيشن. فعلشان كده يعني جايد لاينز دي احدث حاجه هيك اللي هي 2023 just يعني few months ago، انا عامل لها هيك شيرنج سكرين. هم insisting على النقطه دي ان هو
انا مصدق، بس
strokes
الراجل اللي
الكورليشن.
عملها ده بره الجماعه وما خدوهالوش لسه في جايد لاين. هبقى ابعت لك سلايد انا
تمام
في
تمام تمام تمام
بين المحاضرات، وقال ان هو
تمام.
مايل تو مودريت ممكن على اليوم الثالث او الرابع تبتدي.
بالظبط، ما هو الريكومنديشن هيبقى ستارتنج فروم ذا 4 تو 14 دايز على حسب طبعا السايز اوف ذا انفارشن قد ايه. كل ما كان السايز اكتر كل ما كان الريسك اوف هيموراجيك ترانسفورميشن كل اكتر، كل ما كان العكس كل ما كان السايز اوف انفارشن اقل كل ما كان تبدا بدري على اليوم الرابع. ده يعني الموست ريسنت جايد لاينز ريكومنديشن في النقطه دي يعني حاجه. في النقطه حضرتك الكويشن حضرتك سالته، طبعا ده يعني اتس كومن داي سيناريو ان بيشنت بيجي ما هوش عارف الاي اف بتاعه انست امتى، وبتلاقي العيان ان سم بيشنتس هيمودايناميكلي انستيبل. انا اي ثينك يعني دكتور حسن الابروش اللي احنا بنتبعه هو ان احنا بنستارت على قد ما نقدر نكوركت بسرعه الكارديك اوت بتاع البيشنت بفوليوم ثيرابي. ممكن نستارت معاه فازو بريسور لايك نور ابنفرين. usually most of the patient become stable مع هذه الميجرز، وساعتها ابدا مانج عادي الاف ات ايز. اقدر اخد تايم جين سام تايم ان انا ممكن اقدر اعمل ترانسفيجيال ايكو فور ذا بيشنت قبل ما بروسيد فور الكتريكال كارديفيرجن. انما in the situation in which the patient يعني very emergency ومع هذه الميجرز corrected measures مش قادر اصلح، مش قادر augment الكارديك output of the patient، البيشنت عنده signs of hypoperfusion، I am obliged مضطر هيك ان انا ادي electrical cardioversion مع concomitant طبعا anti coagulation. ده لو مش قادر اعمل تي اي يعني للعيان.
ودي مسج صحيحة جدا، ودايما أقولها أول ما تشوفوا إف حاجتين: كله باروكسيزما بيرمنت بيرزيستنت، كله ياخد أنتي كواجلانت، وكله ياخد ريت كنترول. ولو هيمودايناميك انستيبل ليفوفيت رائع، هيقلل الهارت ريت بريفلكس وهيمنتين البلاد بريشر. وبعد كده تفكر بقى تقلبه ولا لأ. رد مايكل قال أفكر أعمله ترانسفيجيال، عشان لو ما لقيتش ممكن أعمل له كارديو فيرجن فعلا. لكن لو لا طبعا هنأجل بقى 4 أسابيع. وده الريكومندد تايم اللي لو في ثرومبس في الليفت اتري ابندكس هتدوب بالانتي كواجيليشن البروبر. انا بعمل كده من غير ترانسفيجيال، بجيب الناس دول واقعدهم 4 أسابيع على انتي كواجلانت دايركت او زمان ماريفان، واعمل كارديو فيرجن بعد ايكو سيمبل ترانسوسيك، وعملناها في رسالتين فيري سيف. فكل عيانين ريت كنترول وانتي كواجريشن، وعلى مهلك بقى تفكر هتعمل ريزم ولا مش هتعمل حسب ايه الحالة طبعا.
تمام
عايزين
دكتور
بقى
حسن.
الاودينس يسألوا لهم اي سؤالات. في واحدة كاتبة بتقول لك انتي كواجريشن هتعمله بالكليكسان ولا هتعمله بايه اللي هتعمله على رابع يوم او 5 يوم؟
ده على اليوم الرابع طالما العين ستابلايزد. طبعا ديبيندز على حسب الكونديشن بتاع العيان وفي كوموربيديتي في ريسك بليدنج ولا لا، بس الدايركت اورال انتي كواجلانت او النواك هو الفيرست تشويس يعني.
في حد سأل على البريجنانسي، ايه اف وز بريجنانسي؟
مانجمنت ذا سيم لايك جنرال بوبيليشن دكتور حسن يعني. طبعا الميديكيشن على قد ما نقدر نحاول افويد الميديكيشن اللي هي تراتوجينيستيك افكت. بيتا بلوكر هو الايديال او البيست ثيرابي تو بي جيفن ذيس بوبيليشن يعني. بيشنت هيمودايناميكال انستيبل اتريال فيبريليشن بيبقى الكتريكال كارديوفيرجن طبعا. هو برضو المانجمنت يعني الكتريكال كارديوفيرجن السيف في البريجنسي.
بص على اسئلة على الشات ورد مايك.
تمام دكتور حسن تفتحها.
في سؤال بيقول لك لو اي اف من غير ستروك ليه دايركت؟ ما انا عايز بستعجل فاحط على طول الكليكسان او انفراكشنت هيبرين. صح، متهيألي طبعا
ما
مفيش
فيش
مشكله.
مشكله، ممكن برضه حاجه يعني نو بروبلم، بس هو الفكره ان يعني انه يكفر عشان اللونج تيرم مانجمنت بتاع البيشنت، انما لو البيشنت
انا
لسه
بتكلم في الاكيوت.
في الاكيوت يبقى ممكن حضرتك نستارت برضه باللومري فلوريد هيبر بروبلم.
في واحد بيسأل سؤال عام: الانديكيشن اوف ترانسجيال ايكو في الاي اف.
اوكي زي ما حضرتك ما لسه منشن دكتور حسن، احنا عندنا البيشنت مانجمنت. لو انا بفكر في الكارديو فيرجن قدامي تو ابروش. الفيرست ابروش ان انا اعمل ترانسفيوجن ايكو فور بيشنت تو اكسكلود ليفت اتر ابندج ثرومبس وبروسيد فور كارديفيجن اوف ذا بيشنت سواء الكتريكال او فارماكولوجيكال. والسكند ابروش زي ما الدكتور حسن لسه منشن ان احنا ممكن ندي ثيرابيوتيك انتوباجوليشن فور 4 ويكس وبعد كده كارديفيجن وزود ذا تي اي. سو تي اي دايما بنلجا له لو انا يعني محتاج رابيد كارديفيجن فور ذا بيشنت، مش هقدر استنى الفور ويكس. طبعا بنكونسيدر التي اي الريسك بتاعت السيديشن معاه على حسب الجنرال كونديشن اوف ذا بيشنت. يعني جيرياتريك بيشنت عنده pulmonary problems، ساعتها ممكن يبقى preference for just anticoagulation for 4 weeks then cardioversion without proceeding for TE.
Any more question? If not نشكر الدكتور مايكل، بالذات إن هو بيتكلم من الشرق، يعني الساعة عنده 12:30 وعايز ينام عشان الشغل، لكن نشكره.
لا خالص
وفاكر
حسن.
الدكتور محمد مجدي برضو قال لي هيقول المحاضرة الأولانية اللي هو قالها في وقت قريب، برضو كانت عن
في تي ستور.
ستورم، في تاك ستورم، المانجمنت في الاي سي يو من غير ما يكون في اي سوفيستيكيشن، مهمة جدا. هيقولها لنا برضو ان شاء الله قريب. وتصبحوا على خير.